aldosterone. And this aldosterone will retain salt and water. So this assumes that you need the salt and water, right? You cannot keep retaining salt and water all the time. Okay, so this whole thing is aimed at retaining salt and water. So we must have a way in which we say, hey, stop, don't give me so much salt and water if I don't need it. So what does it do? It's got a feedback here, all right, in the kidney that helps us prevent secretion of renin. The doctors have a long term for it, and they call it the glomerulotubular feedback. So it's a feedback mechanism. So it feeds back down here to say from here, salt and water up to here, and say, okay, don't make so much of this, and all this will reduce, will stop. And then you stop retaining water and salt. So far, so good? Can understand or cannot understand? A bit tough, huh? Right. Yeah. Well, you know, we didn't take one day to become a doctor. So, yeah. If you don't remember it, I'll tell you what to remember later on, okay? If you can't remember all this, don't worry. Leave that to us. You know, in the clinic, I don't always try and make my patients remember this unless they ask me. I just say, this is the medicine you need to take. I think you also prefer that, right? But for the more academically inclined, maybe you want to know why we're doing all this. Okay, so there we were talking about stopping this. I'm sorry, I think I'm going to go over time. All right. Now, so what do we do? Here are the drugs that we use. So what happened is, this is a normal balance, but in the kidney, because of the high sugar, all this becomes abnormal because the kidney has a mind of its own if you have high sugar, and it just keeps producing angiotensin, right? And it keeps retaining water and salt downstream. So we've got to try and stop this cascade by putting blocks. The blocks we put would be something called an ACE inhibitor. I've listed some drugs in your handout here. Inside it, you've got enalapril, the drug that I wanted to give Mrs. Lim. You can have captopril. You can have Cavasil, called perindopril. You've got a few drugs, okay? Unfortunately, this ACE thing, if you have an inhibitor, you can also produce another hormone in larger quantity, and it makes you cough. So many patients with ACE inhibitors, taking ACE inhibitors, get cough. Then you hate the doctor for giving it to you because you can't sleep because of the cough. So the next thing that happens is the doctor says, okay, I'll change you to another medicine. And I give you an ARB. Okay, angiotensin receptor blocker. Remember receptors? Okay, this blocks the receptors. So that's another group that we can give. And unfortunately, I forgot to list some medicines here, but this is the group of sartans. Okay, you've got losartan, you've got irbesartan, you've got telmisartan. So you've got a lot of sartans. So sartans are ARBs, okay? Then we can use the aldosterone antagonist that prevents the aldosterone from acting. So that's another medication. All right, the latest of all is the renin inhibitor, which acts on renin directly. So if you prevent this, hopefully you can prevent some of this as well. Okay, so that's the entire cascade. The whole thing is inside your handout. All right, remember why is it that angiotensin is so important? Well, this is a diagram of a blood vessel going through the filter. Remember, you've got this ball here that is the filter, and you've got the blood vessel that's running in and out. Well, what happens to angiotensin is that it narrows the blood vessel here, and you find that there's pressure going through. So you have high pressures in the filter, and that pushes more protein coming out. Remember already this filter here was damaged by diabetes, and it's pretty leaky. By making more pressure, it leaks even worse, even more, okay? So we need to cut away the angiotensin, and that's why we give the blockers. So is blood pressure important in diabetes? Yes, definitely. Okay, there's already high blood pressure in the kidney. So you need to prevent the high blood pressure that's outside the kidney as well. All right, now here are a few medical charts that we always show doctors. ACE inhibitors can prevent microalbuminuria because that's going to try and target it right at the beginning before the whole process gets worse, right, in type 2 diabetes. And you see by giving nothing or giving a blood pressure pill with an ACE inhibitor can reduce the amount of patients having microalbuminuria. Microalbuminuria is small amounts of protein. Then you've got ACE inhibitor in type 1 diabetes and diabetic nephropathy. The chance of you needing dialysis or transplant, there's a difference here, about 50% reduction, as well as reduction in death rate. Then you have the SATAN, type 2 diabetes and kidney disease, nephropathy, reducing, doubling of serum creatinine, that's your kidney function, by 25%. Quite a lot, 25%. Reducing end-stage kidney failure by 28%. Then you ask the question, can I use ACE? Why shall I use ARB? Either one will do at the beginning, okay? Because you may be one of those that cough. So the ARB also can be used, all right? What about combos? Nowadays, we're all into combo pills. So there are trials with ACE inhibitor with the spironolactone, which is your aldosterone antagonist. You've got ACE inhibitor with an ARB, and you got the ARB with the renal inhibitor. So we have been using combos, okay? Some of you may actually be on combos without knowing it because there's just too many pills to remember their names, right? But, in order for us to be able to use these medicines properly, we must be very careful of the complication, high potassium. All these pills tend to retain potassium, and high potassium is dangerous. It can stop your heart, okay? The rhythm of your heart becomes abnormal. So Pauline, our dietitian, will tell you a little bit about how to prevent yourself getting high potassium, because doctors are very, very obsessive about high potassium. Once you hit high potassium, they would rather you get kidney failure than have you drop dead. Don't you think that's a good exchange? Right? It's a good exchange, right? You drop dead or you have kidney failure. Which one you prefer? Well, that's a personal choice. But you ask the doctor will say, no, the kidney failure is down the road. Drop dead is almost a certainty if your potassium goes very, very high. So, high potassium. So if you want a chance to control your kidney problem, make sure your potassium is in normal range. Otherwise, your doctor cannot keep adding all these medicines that help to protect your kidney. Low blood pressure is a possibility, but these are among the weaker blood pressure pills. And unless you're extra sensitive, most people don't get low blood pressure with taking these pills, even though they are marketed as blood pressure pills. Okay? Cough with the ACE inhibitor I've mentioned, and some also get a little bit of a rise in the serum creatinine. This is the test we use to check on kidney function. So we remember giving drugs against ACE actually is only one, but it has one of the factors, but has many, many effects. It can help in a little way with diabetic control, blood pressure control. We need dietary protein restriction. It can prevent onset of nephropathy, and it can control your protein. So it works at many, many levels. Okay? Now, this is seldom mentioned, but if you are not yet having diabetic nephropathy, this was one study which showed that if you gave it for blood pressure, all right, if you gave it for blood pressure as first-line treatment, okay, some patients will not use this because it's more expensive. It's one alternative that you can do for treatment of high blood pressure, and in a diabetic, we prefer to use one of these anti-RAS medicines. If you use it, your risk of getting diabetic nephropathy is lowered. Okay, if you use 150 or double the dose, 300 of irbesartan. So in summary, the renin-angiotensin-aldosterone system active locally in the diabetic kidney because of the high sugar. Although it was a system designed to keep our water and salt in check, In the diabetic kidney, it becomes abnormal and it plays a significant part in deterioration of kidney function. Many drugs are now available and act on different parts of the pathway. These have been successful in preventing onset of kidney disease as well as the progression of renal failure. Use of these drugs limited by complication, hyperkalemia, I've mentioned the importance, and usually RAS should not be used in isolation because systemic blood pressure outside of the kidney is also very important. And often we use 2 drugs, 3 drugs or more to keep your blood pressure in check. Okay, now that I have finished, how many of you are on RAS blockers? I see a few more hands. Well, thank you for listening.
Thank you very much, Dr. Choong.